we've got quite a bit of interest for this webinar. We had over 200 people that has signed up. I think there's about 81 people in the room at the moment. I think it's a very interesting area. There's been a lot of discussion, certainly in Malaysia, about advanced care planning, but there is no really agreement on what it means, and there is no national program that looks at ACP in the same way that Singapore does, or some of the other well-developed countries. But I thought that it's an interesting area that we should try and address, certainly from us as a palliative care institution, because it involves the whole issue of end-of-life care and planning for the end of life. And what does it mean in regards to our duty of care medical services? So I felt there were two areas that I wanted to try and address in this webinar. One is the experience of our neighbors across the causeway who's done it for many, many years. What has the experience been about delivering advanced care planning in Singapore? But I think there is also a serious issue of ethics. By having these very serious conversations about end of life care, what is our duty of care in providing this in the role of the clinician, the patient, as well as caregivers, and to some extent the health system, our documentation process. What if patients express their preferences and these may not be met, or really have a very bad experience at the end of life? So we have two wonderful speakers here. I know them both very well, and they'll certainly be entertaining. And I hope that their contributions will lead to a very interesting discussions that we will have some time for after the presentation. So without further ado, I'll introduce them. First is Chetna. Chetna Malhotra is an assistant professor and deputy director at the Lian Center of Palliative Care, Duke NUS Medical School, Singapore. She's put 140 plus scientific manuscripts, but I'm sure it's probably about 1,000 over by now. She's received the Clinical Scientist Award by Singapore's National Medical Council for her research related to ACP, and the research has been funded by prominent organizations such as the National Medical Research Council and Temasek Foundation. After that, we'll have Dr. Sumytra Menon. She's the Deputy Director at the Center for Biomedical Ethics and Co-Director of the Clinical Ethics Network and Research Ethics Support at the Yong Lulin School of Medicine. Wow, that's so long, Sumi. She specializes in healthcare decision-making and mental capacity law. She directs the Science Health Policy Relevant Ethics in Singapore program, and she serves on several ethic panels and clinical ethics committees. And at the end of next month, she'll be in KL doing a workshop on ethics in end-of-life care. So if you want to see her in person, she'll be at Hospis Malaysia at the end of the month. Chetna, you're welcome to join us. So great. So I think that's the introductions done. So let's get cracking, and I'll invite Chetna to start first.
Yeah, thanks, Ednin. Let me share my slides. So thanks everyone for being here, and thanks Ednin for having me today. So I'm going to talk about the Singapore experience and what we have found in our research evaluating Singapore's implementation of the Advanced Care Planning Program, and what we learn about ACP from this. So ACP, as you all know, is one of the most discussed interventions, especially these days, to promote end-of-life conversations. And it allows us to understand and share values, goals, and preferences regarding future medical care. And that's the standard definition for ACP. And there have been several Delphi studies that have been conducted globally and in Asia that have proposed that the main goal of ACP is to provide goal concordant care. So what have we learned about ACP implementation in Singapore? Well, Singapore started the ACP program way back in 2011, and it was modeled after the Respecting Choices program. So during this first phase of the program, it was implemented in acute care settings, and there was a process evaluation of this program that showed that there was low awareness about ACP, lack of systematic processes, and inadequate resources. And importantly, many hospitals lacked a preference supportive culture. So we went and did a randomized control trial to see if this program improved any of the patient outcomes. Our primary interest was in Goal Concordant Care. At that time, it was widely known to be the primary purpose objective of ACP. So we studied patients with advanced heart failure in 2 hospitals in Singapore, and we enrolled 282 patients with NYHA class 3 and 4. And we followed these patients up for 2 years. And since we were primarily interested in Goal Concordant Care, or whether these patients received care consistent with their preferences, we looked at 89 patients who had passed away during the course of 2 years. And what we found that, so this was a 2-arm randomized control study. We had randomized patients into an ACP arm who received intervention by a trained ACP facilitator, and a control arm who continued to receive usual care. At the end of the study, we didn't find any difference between the 2 arms in terms of the proportion of patients who had their treatment wishes followed, end-of-life treatment wishes followed, or CPR wishes followed, or place of death wishes followed. So, end of the 4-year study, we couldn't find any conclusive evidence that the current model of ACP, as implemented for patients with heart failure, improved the likelihood of them getting Goal Concordant Care. Now, notice my use of the term "as implemented," because at that point we were not sure whether this was due to any problems in implementation or was it due to something else. So we looked at what other countries were experiencing. Were we the only ones? And we did a systematic review evaluating all the randomized control trials that have been conducted globally across the world that have looked at efficacy of ACP in improving patient outcomes. We found 132 RCTs between 1992 and 2021. So different kinds of ACP interventions, most of them, not surprisingly, coming from North America. Some looked at only advanced directives, some were communication interventions, and some had ACP as a decision aid. So we divided our outcomes into 2 parts: distal patient outcomes and proximal patient outcomes. So first of all, since we were really interested in Goal Concordant Care, we examined this outcome. We found that out of those 132 trials, only a handful had looked at this outcome. So this is a very difficult outcome to assess. And among those 11 RCTs that had looked at this outcome, only 3 found positive findings. So one of which was in elderly inpatients conducted in Australia, and other 2 in nursing home residents. So basically, all 3 studies conducted in patients who were close to dying. We also looked at other outcomes, patient quality of life. No study on ACP has shown that it improves patient quality of life. There is inconsistent evidence that it improves patients' mental health or reduces healthcare use or changes place of death for patients. We looked at what we call proximal patient outcomes, which is the quality of patient-physician communication. So here the results were brighter. We found a lot of evidence that it improves the communication between patients and physicians, and it influences patients' treatment preferences. It also influences the caregivers. So it leads to the discussion between patients and caregivers, leads to a congruence between patient and caregiver preferences, and it has the ability to improve bereavement outcomes, although I would say more research might be needed here. But yes. So in a nutshell, ACP programs globally have not been found to facilitate Goal Concordant Care unless they are being implemented in patients who are close to dying. They also may not influence other key outcomes that many people, or especially policymakers, are looking to address. So if you're looking as to implement ACP as a way to reduce healthcare costs. That perhaps may not happen. However, what ACP programs may do is that they improve communication between patients and physicians, and they have the potential to improve caregiver outcome. Now, the big question I'm going to talk about today is, why does this happen? And what exactly does this mean for ACP implementation? And this is a question that has been debated over and over again in the last 2-3 years. So on one hand, you see there have been studies, as I mentioned before, Delphi studies that have prominently shown that goal concordant care is the primary outcome for ACP, and that's what we should be chasing. On the other hand, others have questioned the value of advanced care planning and whether, because it's not improving any outcomes that we really care about, patient quality of life, healthcare costs, maybe it's time to do away with ACP. So let's try to find out a bit more about what might be happening here. So during this time, in recent years, Singapore just has completed the phase 2 of its ACP program. And ACP during its phase 2 was implemented in inpatient and outpatient setting in public hospitals, primary care clinics, and nursing homes. And this time, there was not only an increased focus on improving awareness and integrating ACP in clinical workflows, but also a greater focus on developing processes for goal concordant care. So coming back to my original question, is this because of the way we are implementing ACP, or is it something else? So we decided to look deeper into how we are implementing ACP. We did a process evaluation this time, and it was a mixed method study, but today I'll just talk about the focus group discussions that we did as part of this study. So as part of these focus group discussions, we went around and interviewed all healthcare providers who were involved in ACP implementation. We divided them into 3 groups. First group were the clinical leads and clinical champions. So these were the ACP leaders who were responsible for implementing ACP within their organizations and within their departments. The target 2 category was people who were doing ACP on the ground, the physicians, the trained, dedicated ACP facilitators, and those who referred patients to these ACP facilitators. We call them advocates. And the last special category was nursing homes. So again, apologize for the very complex diagram here, but we used a very well-known implementation science research framework called the Consolidated Framework for Implementation Research, which primarily divides all of the factors that we assessed in outer setting, inner setting, healthcare professional characteristics, and processes. So I won't talk about each of them, but just highlight some of the very key factors that came up. Okay, so what did we find? So outer setting refers to things that happen outside of individual organizations. And one of the things we found that although awareness had improved over the years since ACP 1.0, people were still not ready to engage in these ACP discussions due to cultural barriers. So the way organizations were funded under the ACP 2.0 program is that funding was linked to the number of ACP documents each organization completed. So the more ACP documents completed, the more funding went to each organization. Now you can imagine the implications of having this. There becomes an increased focus on completing the ACP documents, because that is what we are monitoring the success of the ACP programs. How many ACP documents has each organization completed? And it really shifts the pendulum towards documentation and a checklist approach rather than measuring and having the conversation itself. In terms of inner setting, which is the factors within each organization, we found that organizational leadership was really important. So when the leader, when there was a strong mandate from the organizational leader, we found that it increased the priority for ACP within that organization. In the absence of strong leadership, we found that only certain departments like palliative care department, geriatric department, only they were implementing ACP. Physicians, we found that they were less engaged in having ACP discussion. This was, in a lot of organizations, this was considered the work of medical social workers or dedicated ACP facilitators. And a big problem here was the length of the conversations and documentation process. So as you can see from the quote here, many physicians didn't want to bring up ACP during their routine conversation because it just took so much of their time and they had so many things to do. And they felt that there was little organizational recognition for the time they spent in having ACP. A paucity of dedicated resources. Now, this was especially important for nursing homes because we are having this ACP program, which is being implemented there. So having an ACP at the time of when the patient enters the nursing home, that has become part of the workflow. But what happens when you have an ACP document that says, I want comfort care, I don't want to go to the hospital, but there are no resources within the hospital to support the patient within the nursing home. So what do we do with that ACP? Processes. So we found that training of ACP was sometimes inadequate, and about half of the providers who were trained to do ACP facilitation, they never had this discussion because they lacked confidence in having ACP. So they needed more in-depth coaching and mentoring for having these conversations because it was scary for them to start having these conversations suddenly independently. And these conversations tend to be very complex and time-consuming, and so is the documentation process. And as I mentioned earlier, this dissuades a lot of physicians from having these conversations. And even a lot of patients don't have these discussions because it just takes too much time. And even if these conversations happen, often at times they're not documented because documenting them, then uploading them on the IT systems takes a lot of time. So the whole process has become very tedious. And even when they're uploaded, many physicians who are going to be ultimately using these ACP documents, they don't know how to retrieve them. And especially in emergency settings, there might be lack of time in retrieving these conversations. And if the documentation is incomplete, for instance, if it lacks signatures, or if the patient couldn't complete the conversation, we couldn't mark everything on that ACP document. It's marked incomplete, partial, and it doesn't show up. Importantly, I think we need to do better in terms of continuously monitoring and evaluating the ACP that we're implementing in a more comprehensive way. Currently, what we do is we count the number of ACP documents completed, and very few organizations are actually monitoring other outcomes. So coming back to our original question, why does ACP not facilitate concordant care or improves patient outcomes? So one of the factors we discussed could be related to due to these issues related in implementation. So these organizational factors, policy factors, and if we can fix these issues, we can make our implementation process better, and maybe we can have improvement in the outcomes. But there's another thing that I would like all of you to understand here, and I call that instability in patient preferences. To understand a bit about it, maybe step back a bit and think about the last time you went grocery shopping empty stomach. And at least when I tend to do that, I find myself buying a lot more stuff than I would usually do. Now, what I would need for coming week shouldn't ideally be determined by whether or not I'm hungry. But it seems that I'm making decisions that satisfy my preferences that exist in the present, but not in the future. And we call this projection bias. And it's problematic when there's a mismatch between how we are feeling right now and how we will feel in the future. To give another example so we can understand this better, there was a landmark study that was done in 1980s about women's decision during childbirth for analgesia. So these investigators, they interviewed a group of women 1 month before labor. And most of these women said that they would avoid analgesia. When these women were again interviewed during labor, when they were experiencing pain, they changed their preference and they said they would want analgesia. 1 month after labor, when they were no more in pain, what was very surprising was that these women said, yeah, I could have avoided analgesia. So why were these women going back and forth, back and forth? It seems that and this was true for women who were experiencing both childbirth for the first time and those who were giving birth again. So it seems that these women, when they were without pain, they were unable to appreciate what they would want when they will experience pain, or how that experience of pain will influence their preference for analgesia. And it's also what we call hot-cold empathy gap. And closer to end of life, there have been studies that have looked at hospice patients' will to live. So a study published in Lancet in 1990s, they interviewed hospice patients every 12 hours or so, and they recorded their will to live. And as this diagram shows, a particular case for 82-year-old women found that patients' will to live really fluctuated with their level of pain and distress. So when the pain levels were high and distress levels were high, will to live was low, and vice versa. So will to live wasn't a reflection of patients' long-term assessment of their medical condition or happiness, but it was dependent on what they were feeling at that point in time. So we shouldn't be making any drastic decisions based on some momentary assessment or a one-time assessment of patients' preferences. And so we decided to dig deeper into this. And I looked at stability in patient preferences among different groups of patients, heart failure, cancer, and even caregivers of people with advanced dementia. So remember the results from the heart failure trial that had shown earlier. So I took data from that trial and looked at 200 patients whom we had surveyed over a period of 2 years. And during the survey, we had asked them whether they wanted non-aggressive end-of-life care or aggressive end-of-life care. So at baseline, half of the patients said that they want aggressive end-of-life care. This is typical of patients with heart failure. But what's interesting is that, so what you see in this diagram is horizontal lines. So each line represents preference from a single patient. And what you can see here that is over the course of the 24 months, many lines are changing color. So blue lines change color into red, red into blue, blue again, and so on. And this indicates that patient's preference is changing over time. And converting those into numbers, we found that by 4 months, more than a third of patients had changed their preference. And by 12 months, more than 50% had changed their preferred end-of-life care at least one time, and by the end of the 2-year period, more than 60% had changed at least one time. And we had similar findings for patients with cancer and caregivers of people with dementia. So very consistent. And across all of these studies, we found that change was not consistent in one direction. It was influenced by what was patient's mood at that point in time, what was patient's health status, physical health status, symptom burden at that point in time, and what information they had at that point in time about their prognosis. And as these things change, patient's mood changed, patient's symptom burden changed, quality of life changed, patient's awareness about their prognosis changed, preferences also changed. Now, again, so what does it mean for ACP? So we saw from our systematic reviews and our own Singapore experience that ACP was unable to achieve goal concordant care and improvement in many patient outcomes like quality of life and healthcare costs. And that might be due to two reasons. First of all, we discussed gaps in ACP implementation, but also that patients' goals and preferences are transient. Now, if they are transient, this really makes goal concordant care a holy grail, because we are trying to chase something that is so momentary and transient that achieving goal concordant care really becomes very difficult, even though that is something we all want. So what does it mean for ACP implementation? Now, we looked at two sides of the debate earlier. One, that we should be promoting ACP as a way to achieve goal concordant care, and another, that we should do away with ACP altogether. So which perspective is correct? And maybe we can have a great discussion later, but I just want to propose a third perspective here, that we rethink our objectives for ACP and accordingly how we implement it. So what I propose is that the goal for ACP is to educate patients about the illness, more seriously ill patients. And again, we have extensive data about this, not just from Singapore, but globally. Most patients do not understand enough about their illness trajectory, their prognosis, even caregivers as well. So a goal of ACP conversations should be to educate patients and caregivers about their illness and prognosis. Now, ACP is a communication tool that enables sharing of patients' values and goals. It allows patients and caregivers to engage in a shared decision-making process. And this can be used to guide their current decision-making. And as people's goals change, ACP conversations need to be a continuous process. And slowly, so we start with current decisions, and slowly we can start talking about what future may look for them. And in this way, we help prepare patients for future end-of-life decisions. So preparation rather than planning can be an objective for ACP. So how do we measure success of ACP, if not goal concordant care or quality of life or healthcare costs? I think we need to start looking at alternative indicators of measuring ACP. Do patients and caregivers really understand their illness and prognosis? Are patients able to share what's important for them with their providers and with their caregivers? Do providers and caregivers understand patients' values? Does it lead to improved relationships? Are patients able to participate in this treatment decision-making? Are current treatments in concordance with their values and goals? And very importantly, do patients and caregivers now feel prepared for future end-of-life decisions? And caregivers during bereavement, do they express less regret and distress? So what benefits do we have of reimagining ACP in this way? It helps to situate ACP during the current decision-making process. So it shifts emphasis from a more, future decision-making, which more people usually procrastinate, and don't want to think about to something that is more immediate, which is more actionable, and it becomes part of ongoing care. In this way, ACP discussions become more normalized and they become a dynamic process rather than having one-off discussions. Happy to have hear from all of you during Q&A. Thank you. That's all from me.
Thanks, Chetna. I think it's been very fascinating to look at the amount of work that has been done in Singapore, and especially the amount of research and evidence base that's been accumulated over the years with regards to ACP. I think that's been really wonderful to look at, that it's been done in a very evidence-based mechanism rather than just an opinion-based. So
Yeah,
I think,
sorry, Ednin, I had to go really fast.
okay.
But I'm happy to offer more clarifications, share more information later.
I think it will certainly bring quite a few discussions afterwards. So hang on there, and let's have Sumi to have a discussion on some of the ethical issues around this.
Thanks, Ednin. Hi, everyone. I'm just preparing the deck of slides, which hopefully will work. Hello, everyone. Good afternoon. Lovely to see so many of you here. I'm not presenting research results, so this is going to be a much shorter deck. It's more of a conversational kind of thing that we're going to be discussing the ethical aspects in relation to advanced care planning. And as Chetna has already alluded to, very happy to continue this discussion after I finish my presentation. And of course, thank you very much to Ednin and the Hospis Malaysia team for having me here. So I think I don't really need to tell you what advanced care planning is, seeing that Chetna has already given you a very good description and also explained the implementation process in Singapore. But basically, the idea behind it, at least from an ethical perspective, is that we would like to honor a person's autonomy by helping them to consider their healthcare preferences and values so that we can get to some of their wishes and preferences, and that can hopefully guide some healthcare decisions, even if they lose decision-making capacity in the future. Because obviously, if somebody has capacity, they will be making their own decisions at the time. So those preferences and wishes and their values that they may express will be only carried out or discussed in relation to how to be carried out when the person actually loses capacity. So it can, I suppose, give the person a sense that, you know, their own wishes and values will be respected even after they've lost capacity, and that the healthcare team and their family members would follow through with it. So in the conversations, I totally agree with Chetna on this. In relation to the goals, rather than trying to complete the form and tick all those boxes and submit it, it's really important to explore the person's values, their beliefs, their culture, again, so that these can be used to guide healthcare decision-making in the future, rather than focusing on specifics about, you know, do you want CPR or don't you want CPR? I think we need to be looking at people more holistically. Otherwise, we are coming up with too narrow a set of parameters to determine what we think the person may or may not want. And that might not really promote their autonomy at all. So when we're thinking about autonomy, and autonomy really is a very tricky word, and maybe misunderstood in large, in many ways. I mean, autonomy really isn't about giving you what you want. There's sometimes you can get what you want, but sometimes you can't get what you want. It's really more about respecting the individual. So active engagement in advanced care planning can foster someone's autonomy when we are considering their values and preferences. And healthcare professionals really are obliged, I think, to maximize the benefits and minimize harms when caring for someone. And this is usually when they are providing care for the patient, and that will be carried out in their best interests. But we do have to remember that competent patients, their decisions we do tend to have to respect them, even if the healthcare professional doesn't think that the decision that they've made is in their best interests. But also do note that patients can't demand treatment that's medically inappropriate. So that would be in the context of whether in the situation where the patient has capacity and is talking to the doctor and the healthcare team about it. But the same also applies in the advanced care plan, right? They can't be saying, I want this, when what they want might not be appropriate for them. So when we think about family members, as well as healthcare professionals, they both obviously play a very important role. I think most families and most patients won't initiate conversations relating to future care planning for the healthcare of the patient. And this may be for very many reasons. They may have other things that they're worried about, other priorities, and they may not know how to initiate a conversation like that anyway. So I think it's really incumbent on the healthcare team to initiate those conversations, to explore the values and preferences of the patient. Now, in Singapore, at least, and I'm not sure what the plan in Malaysia is going to be, but the patient is encouraged to nominate one or more close family members or close friends to participate in the advanced care planning discussion so that everyone is involved and aware. The idea being that, when you are having these conversations, the family isn't blindsided later on when they find out actually the patient expressed these preferences and they had no idea that this was what the patient had in mind. So assuming that the patient is happy to have a trusted family member or other loved one there, then that would actually be a very helpful dynamic in the conversations between the patient, the family member that was chosen by the patient, and the healthcare professional or whoever the facilitator might be. So family members and healthcare professionals can actually foster the individual's autonomy and doing this respectfully, right? So checking about their preferences and understanding the basis for the expressions for the preferences that they have made. I think one thing we have to be very careful about is the involvement of family members. And of course, while I think everywhere around the world, families are loving and well, maybe not all families are loving, but many families are loving and close to their relatives. Sometimes families can also do the reverse and suppress the autonomy of the patient. Sometimes that's direct and sometimes it's not so direct. Sometimes it's overt, sometimes not so overt. Sometimes it's intended and sometimes it's not intended. So family members in their role here, it's more of a supportive role, an understanding role, a facilitative role. So it shouldn't be their role to bully or force their views on the patient. But of course, they can respectfully ask questions and they can gently persuade. In relation to providing necessary information, obviously this is again very important, and Chetna has mentioned how important health literacy is. We really do need to do a better job, I think, of helping and supporting patients on their journey to understanding their disease and various conditions. So providing relevant information at the pace and in a way that the patient and or the family members can understand, I think is quite an important thing. So it's providing an objective overview of the risks and benefits and including also option where no treatment might be appropriate, right? So sometimes, it may actually be better not to carry out that particular form of treatment, but that doesn't mean that the patient shouldn't get care. Patients should definitely get care, and if at the end of life, definitely should get palliative care, but maybe not such an aggressive treatment option, because this will help them with understanding on a more informed basis what their options are, and they can make a more informed decision. And of course, healthcare professionals also should be giving alternatives, and these are alternatives that are evidence-based, and again, including the benefits and risks of those possible treatments. Now, beyond sort of just providing those benefits and risks, I think it's an important role that healthcare professionals can play in terms of helping patients understand the consequences and anticipated implications of their preferences, right? So sometimes they may express they would like this or they don't want that, but they might not necessarily know what the implications or consequences are. And I don't mean that in a disrespectful way. It's simply because they may not have enough of the healthcare context or knowledge to understand that these are the consequences and implications. And it's incumbent again on us to be able to explain to them, that these might be the consequences and that could come from a particular decision. And so again, that informing them and also correcting any misperceptions, right, is going to be very important. And this is, again, the respectful asking about a person's rationale for requesting a particular treatment or refusing it is going to be quite important. Now, collusion, I mean, I think in Singapore, obviously it still exists. I imagine it exists in quite a few countries around the world. So, you know, we do know that families very often think that they should be protecting other family members, usually those that are perceived to be older or more vulnerable, from perceived anxiety and distress. And they may try to offer this protection through asking healthcare professionals to withhold prognosis or diagnosis. Now, I think it's going to be very difficult to have any kind of advanced care planning conversation with a patient if the information is withheld, because then again, you know, individuals are not aware of their actual medical condition, and we come back to this loop of not understanding your healthcare condition and perhaps health literacy, which is not optimal. But there will be rare circumstances where you know, some information may have to be withheld, or at least for a particular time. But even when we're talking about disclosure, please bear in mind, I'm not saying that healthcare professionals should just blurt everything out, and it could be very terrible, and the person might find it difficult to accept. You know, disclosure about prognosis and diagnosis can be staged, right? In steps and in pieces. It doesn't have to come all out at once. I get asked this question quite a bit, or at least maybe it's questions I'm generating in my own head. Is ACP for everyone? And I think the answer to that is no. I wish it was a yes, but I think it's a no. And the reason I say that is I think not everybody is willing or ready to have an advanced care planning conversation. And I think the other thing is, you know, when I'm thinking even about defining what it means to have an advanced care planning conversation, I think there could be several kind of iterations of versions of this, right? You could have like the full works where you have a sit down with an advanced care planning facilitator, which you know, could be a doctor, a nurse, or other trained professional, and you know, your loved one and yourself, and you know, you could have this whole long conversation about it. But then I think there are also opportunities that we really need to take, you know, we should seize on more deliberately. And those are having bite-sized conversations with your patients over time, which I think are especially important. And, you know, Singapore is moving on to this Healthier SG program where they're trying to have you paired to a particular general practitioner for a longer period of time. And again, you know, as you're older, perhaps, you know, see a geriatrician, you know, more consistently over a longer period of time. And now, if you've got a relationship like that, I really do think there's a very good opportunity to build that sort of trust and understanding between the patient, the healthcare professional, and the family members if they come along to these consultations. And bit by bit, I think you will get to know, as a healthcare professional, you'll get to know your patient, and you'll get to know the dynamic of that family. And that, I think, is your best opportunity in relation to building this sort of long-term understanding about what the patient's values, wishes, and preferences are. So no one should be forced to do it, but I think we need to be doing this more proactively on a regular basis with patients and with families. And we need to think about, you know, exploring slowly. And again, when I say slowly, with some patients it'll be slow, with some patients it'll be fast, some patients will be intermediate, right? You have to take your cue from them, not from what we want, not our agenda, in terms of the timing or filling out the forms or having them submitted. But we need to be thinking about gauging their readiness for it, and you know, perhaps preparing them for it. But there will be a group for whom, you know, they do not want to talk about this. And, you know, I think we do have to respect that, whether we like it or not, because I don't think you can force them to participate if they're not willing to do so. So pick your timing wisely. And I think totally agree, public engagement, I think, is really, really essential. I think Singapore was, if I dare I say this, quite gentle in its approach on advanced care planning for very many years. I think we need to be far more confident in our approach on going about this. Though I do think we've done that probably in the last 5 years or so. We've sort of everywhere you go in a healthcare institution, you'll probably see posters of ACP. So we're kind of getting it into people's consciousness, which is great. And I think the other thing we really need to be aware of is advanced care planning shouldn't be something that we are just looking at the end of life. It's something that we should start much earlier in our care of a patient, right? Probably, I don't want to say you have to hit a particular age or have a particular condition, because again, we have to take care of the patient, but it shouldn't be something we should be talking about literally when they're about to die, but ideally we want to bring it up earlier and get to know our patients better earlier. Certainly, a serious ish disease or a start of a chronic disease phase might be opportunities to start conversations with patients and or their loved ones. So to conclude, I'm doing well for time, I think. I do think that ACP gets patients thinking about something they would not normally think about, right? There's still, I think, a lot of taboo and misunderstanding, especially with some patients and family members, about what advanced care planning is. So I think we need to plant the seed early, and we need to nurture it, water it, tend to it, fertilize it, whatever. So we need to be doing that, rather than kind of suddenly parachuting this whole idea of advanced care planning in, and then you're already nearing end of life and it's all very fraught. And no, I don't think we should be doing that so much if we can possibly avoiding it. I do think it facilitates discussion about their wishes and preferences in healthcare, and I think that's a good idea. But for some patients, I'm not sure how big a group it is. It could be very difficult to broach these sorts of topics with them for various reasons. It gives, I think, patients a voice to express what they would like, and hopefully, it will support. I don't want to say Goal Concordant Care, but I'm hoping we're going to honor at least some of their wishes to the extent that it's possible at the end of life. And I think it does loop in the loved ones. And I think that is very important for those of us who do have families, and many of us do. Mind you, though, increasingly, if we look at the when we're not making enough babies, we're not reproducing ourselves. So maybe that's also going to be changing in the future. But families do have an important role, and we are a family-centric society. So if we do have those family members around, it's lovely to get them involved. And they can play a very supportive role and to foster the person's autonomy and to support decisions that would benefit the patient. So from the healthcare professional side of things, I think it's a great opportunity to inform patients. I don't really like to use the word educate, because I think, it kind of a little bit look downy, but I think to inform them about their health conditions, and enhance health literacy, put them in a position where they're more in the driving seat and have a better understanding about themselves and the proposed, the likely trajectory of what their health condition means for them and future implications. I think it does help healthcare professionals better understand their patients, their values, their preferences, their family dynamics, and it definitely connects them up better in terms of again, the relationship with the patient and the loved ones. Hopefully, it may reduce uncertainty regarding decision making when the patient loses capacity. And just to finish off, a decision that aligns with patients' preferences is usually likely to be in their best interest and will be beneficial to them. Okay, and I think that's about it for me. I'm happy to take whatever questions you might have. Thank you very much. I'm going to stop sharing now.
Great. Thanks, Sumi. Thanks, Chetna. I think we've had two brilliant presentations. I hope it has generated some thoughts about ACP, the focus of ACP, the conversation, the documentation, the processes, our duty of care to patients. When should it be introduced? How do you document these things? The discussion of Goal Concordant Care, if we are unable to deliver what the patient wants, what's the point of it? So I do have quite a few thoughts about it, but I also want all of you to think about questions that you might want to ask. But I'll start whilst people are thinking about some questions, I'll start with Chetna first. Singapore has done it in a nationwide exercise. And community involvement, everyone is supposed to be aware of it. How do you think it can be done if ACP is purely be discussed ad hoc in one ward, in one hospital, but not as a population program? How do you then document these things or capture these things if a patient has expressed their care preferences in one hospital, and in an emergency setting, they end up in another hospital where these conversations are not recorded? So I'll pass that to Chetna first.
Yeah, thanks, Ednin. Thankfully, Singapore's built a great IT system so we have a national health electronic record system that allows providers from across the country to view the ACP documentation. So wherever they have done it, doesn't matter, but everybody across the board in any institution should be able to access through the National Health Electronic Records their ACP document. So yeah, it's a great system. While I did mention that there are limitations in terms of what we can upload, because there's a definition of completed ACP documentation. So, I mean, to Sumi's point, I absolutely concur that having bite-sized conversations is a great idea. And I think that's how it should be, conversations happening over a period of time. But then it's not complete ACP documentation. So yeah, that limits sharing. So yeah, we do have a great system, but yeah, there is potential to expand further there.
That leads me directly to Sumi. If a patient has done an ACP in one setting and ends up in another hospital and their ACP has not been accessed, what is the duty of care for that doctor if the patient says, well, I've done something and that my wishes are not being looked at? Or what would be the duty of care or the ethical issues there, Sumi?
Well, luckily, the patient's actually saying, I've done an ACP, please go and look. All right. So the National Electronic Health Record, which will, be mandated by law when the Health Information Act is going to be passed likely early next year, means, everybody should have access to this. And it's available as a button in the corner of the National Electronic Health Record. So it's not buried somewhere. But having said that, I take Chetna's point about, these bite-sized conversations at the moment might not have a place in the National Electronic Health Record. But I mean, if you're a patient and you're going in to another hospital and your ACP was made in a different hospital and you're telling the doctor, I've made an ACP, go and have a look at it. But the thing is, do they need to have a look at it? If they're telling the doctor that, I assume they have capacity. So a doctor should be saying, well, let's talk about your condition and what we can do about it, rather than looking at the ACP right at that point anyway.
A follow-up question would be interesting, Sumi. What is the importance of having a Mental Capacity Act in the provision of ACP?
We've had ours since, out in 2008, passed since, in force since 2010. So it does, I think, help because it does provide the guidelines or the principles, at least in relation to how best interest decision making should be carried out, the factors that you need to be taking into account when you're balancing benefits and burdens. Of course, it doesn't give you a clear algorithm, if this, then that, if this, then that, and then it gives you a formulaic answer, but it gives you the kind of guide rails around it. I think having a definition of capacity, laying out what happens with decisions when somebody lacks capacity, being able to appoint a donee of a lasting power of attorney to make certain decisions. And in Singapore's case, only allowing doctors to make decisions that relate to life-sustaining treatment and treatment to prevent a serious deterioration in a patient's health, certainly, I think, gives doctors a certain degree of confidence when it comes to recommending certain treatments to patients who've lost capacity and managing the dynamics with the relatives.
There's a question here that probably leads to that. What is your thought with regards to surrogate decision maker nominated by patient if the patient (wife) separated but not officially divorced with husband? However, she nominates her daughter on behalf of her to decide for her according to her best interests in case she is mentally not fit.
You should be able to nominate whoever you like. You don't have to nominate your spouse if you don't want to, and especially if it looks as though your marriage is on the rocks, you don't trust the person, then please appoint somebody else. And just, if you allow me one more thing, when you're making a lasting power of attorney, please only nominate somebody that you trust unconditionally. At least in the Singapore system, they have quite a lot of power, but you do want to trust somebody, at an extremely high level.
There are two questions which I think is linked. I think that Chetna is your best place to deal with it. How do you measure success indicators such as patient understanding of their illness or their readiness for future decisions, given that these aspects are subjective? And to hear your thoughts on the direction of research in determining the effectiveness of ACP for the future.
Yeah. So great questions. Yeah, we don't have great measures, great quantitative measures, I would say, of assessing that. So it's still work in progress. So there has been some work that was published in Journal of Pain and Symptom Management about coming up with a scale or measure to assess patient preparedness for future decision-making as an outcome for ACP, but it was in context of renal failure patients. So I think there's potential to expand that and do it across illnesses. So that is definitely ongoing work there.
Chetna, why does Singapore implement ACP when the research doesn't show very good outcomes, certainly in Goal Concordant Care, certainly in the distal goals?
Ask Sumi, she's on the steering committee.
What's the point?
Okay.
No, go on. I was going to say it's a work in progress, but
So brings me back to that debate around ACP, Ednin. Should we completely do away with ACP? Or should we continue to focus on Goal Concordant Care and see like, okay, maybe we can get it if we get everything right and we can really make it work. So what I'm trying to suggest here is that ACP shouldn't be about Goal Concordant Care. And we shouldn't do away with it. So ACP is about having that conversation with your patients. ACP is about having your patients talk to their caregivers, to their family members, whoever they want to talk to, as Sumi said. So it's about the conversation, and we shouldn't let that conversation, we shouldn't throw away that conversation.
Do we mean different things when we talk about ACP, serious illness conversations, and goals of care conversations? Are they the similar things?
In my mind, they're the same. It's part of ACP. Yeah.
I've got Zinni putting a hand up there. Zinni, do you want? You didn't put a question in the chat. Do you want to sort of unmute yourself and
Hi, Sumi.
present your question?
Hi, Prof. Chetna. This is a question to Prof. Chetna. I would like to hear your thoughts on how best to monitor as well as to measure the quality of GOC or ACP conversation and ensuring that it's not a tick box approach.
Yeah, so again, I would say this is something work in progress. But importantly, are we touching upon, the important thing to remember is that it's about it's about, again, I know Sumi didn't like the term education, but it is about telling the patient what the illness means for them. So are we doing a good job with there, right? Are we doing a good job of eliciting what is important for patients? Do patients and families feel prepared for future decision making? Again, we need to come up with good ways of measuring, but I think these are the three important domains that need to be included when we are trying to assess the quality of conversations. And not one conversation would include everything, and maybe it shouldn't, right? But if these things are happening over time, then it's good implementation, I would say. It's good quality conversation.
Are there any other questions that anyone wants to ask? Can you type it into the chat box? Do I see anything? Okay, there's one at the top that I forgot. What's the definition of Goal Concordant Care used for measurement in the research mentioned? What are the common goals that are brought up for discussion with patients and their family?
So we looked at the ACP document, and the ACP document for heart failure patient asked them whether they want CPR, yes, no. Which type of end-of-life treatment they want. Do they want comfort care? Do they want limited intervention? Or do they want full treatment? And it asks about their preferred place of death. So we asked the same question for all patients in the survey as well. And for the patients who had passed away during the course of the 2 years, we went and looked into each and every patient's medical records manually to assess what care they actually got. Where did they die? Whether they got CPR, and we classified their treatment into comfort care, limited additional intervention, and full treatment. And we matched for each patient whether what they told us matched with what they got. So that was our way of defining goal concordant care or end-of-life care consistent with preferences. Of course, different people have done it differently. Some have asked bereaved caregivers with what they felt, whether their patients' goals were respected or not, and there are pros and cons for each method.
Thanks, Chetna. Dia, I see you there. Do you want to unmute yourself and sort of ask your question?
Thank you, Ednin. Sorry, I cannot use my video. Hi, Sumi. Hi, Chetna. Nice to meet all of you there. So we all agree that we fail to achieve goal concordant care with advanced care planning. We cannot actually that easily plan. So we all agree about the value of values exploration, the importance of values exploration in the conversation. So do you think actually our problem is the term or the name advanced care planning, in which actually we cannot plan? Do you think it's still an appropriate term or name for this process, especially when probably it can add burden to the healthcare professionals, knowing that we tried to explore, understand the patients, but actually it's not necessarily helpful in planning the future for this patient. Thank you.
Yeah. Sumi, you want me to go first? Okay. Thanks, Dia. Awesome question. And I actually didn't bring up rebranding ACP because I didn't want to be too controversial. But you hit it on the spot. Yes, we need to rebrand ACP. So in the systematic review that I had shared with you, I actually recommended that we need to rebrand ACP, and my suggested term was advanced care preparation instead of planning. So it still remains ACP, but we're talking about preparation now. We're not talking planning. And you might have different views and would love to hear from you how a rebranded ACP might look like. Happy to take different perspectives as well. But yes, we really need to do it.
Sumi, your thoughts?
Yeah, I mean, I don't know whether the problem is with the name or what we have said it's about. So it could be, if we're focused on filling out this form, which has the boxes and the ticks, and we're talking about, do you want CPR, do you not want CPR, and things like that, then I think that's a problem. So, whether we retain the name or not, and I'm open to keeping it or not keeping it, I think what needs to change is what is it that we're doing with patients, and what information are we collecting from them, and how are we documenting this, right? So we need to have forms that actually allow us to explore those values and preferences and to build it up over time so that we can get a better picture of the patient in understanding what they would like further down the line in relation to their care preferences.
Following on that, in UK, they had the whole experiment with the Liverpool Care Pathway program, where it became a bit of a tick box process. How much of that do you see within the Singapore context, that the ACP is a tick box process? That it's much more, try and complete as many ACP forms as you can.
I think our healthcare professionals are very good. I mean, while there has been in the past this sort of, focus on completion, we do also, have a worksheet, right, that goes with the form that's ultimately submitted. So the worksheet is actually where all the valuable information is, because that's where you can really document the discussion, rather than focusing on the final form, which then becomes, a little bit more of a, yes, no kind of option form. But all these things are improving. So that's one thing I think Singapore is quite good at, generally speaking. we will study it. We will look at it. We will get it reviewed, and we will take on board the recommendations and try again.
The other thing that worries me a little bit, Chetna, when you talk about projection bias, and that's where the issue of authenticity come in. And in that sense, what do you feel would the required level of training for an ACP facilitator to have in having these conversations, to really have the authentic person, to have as little sort of projection bias, and to really get the real value and nature of the conversations that are needed to be documented in the ACP document?
Yeah, clearly a one-day training workshop wouldn't be enough, right? So
what would be enough?
Again, there's no set criteria, but I think mentoring, coaching over a period of time, trying to understand what is the key goal that we are chasing here. Is it we're trying to complete a form, or is it we're trying to really understand who the person is? And what is it that they care about? What is it that matters? So I think getting that perspective and getting the mentoring and coaching over a period of time gives people more confidence than a one-time training workshop. And that's where I think, and we clearly saw in our process evaluation that organizations that were able to get that sort of mentoring and coaching were doing a much better job of being able to, I mean, there was a much higher rate of ACP conversations there, however we define it, compared to organizations that didn't have that mentoring and coaching process in place. About projection bias, I think that's very hard to, completely rule out.
I agree.
And yeah, but I think that only tells us don't just rely on what patient is telling CPR, yes, no.
Yes.
Right? I want to be in the home. But when the time comes, of course, preferences will change because patient caregivers will panic. They'll take the patient to the hospital. And that's a reflection of evolving nature of patient's communication. And what it's reflecting as is changing treatment preferences. But patients and caregivers are just reacting to their evolving treatment preferences. And we need to respect that.
Absolutely.
So
Yes.
that they will evolve over time. So that's why chasing Goal Concordant Care is very hard.
Sumi, how many how do I phrase this? Have you noticed any increase since you have ACP in Singapore to the number of people requesting for advanced medical directives and legal power of attorneys?
Nope, I don't think so. It's been quite well in terms of advanced medical directive. No, right? Because that's a pretty hopeless document, and we should need to get rid of it. It's no longer fit for purpose. So that hardly anybody's done that. But mind you, having said that, there was definitely a rise all across the board, right, with LPAs and other tools in terms of planning when we had COVID. It kind of increased the awareness suddenly. People realize, oh my God, I could die from this thing. So, there was this increased awareness, and there was an uptick in relation to that across the board at that time. It's kind of settled back down now, I think.
A question I sometimes get asked is, what is the legal status of an ACP document?
How long is a piece of string? Are you asking in the Singapore context?
I'm asking you to answer in any context that you wish.
Look, it's a pretty powerful, well, not even just an advanced care plan. I don't think it needs to be on that form with the tick boxes for it to have to carry weight. I think your preferences that are expressed, which hopefully will be documented in the medical notes, so hopefully your doctor has been doing that, or if you have expressed them yourself in any form, document, video, or whatever it is, that does carry weight. I mean, when you're looking at weighing up the best interests of somebody once they've lost capacity, the person's expressed preferences go pretty much to the top of the list. Of course, like I've mentioned earlier, we can't demand treatments. You can't demand inappropriate treatment, certainly, even though you've wanted it and you've videoed yourself requesting it. So there are limits to it, but your preferences are pretty powerful, and it doesn't have to be in through a form for it to carry weight. There is an ethical weight behind it as much as a legal one.
There's a question here which says, I'm not sure from where. May I check why the worksheet is not uploaded onto the NEHR, and are there any plans for it to be uploaded? I'm assuming this is Singapore.
Yeah, there have been discussions about uploading it. So
Okay.
so I hope yeah
Not yet.
I hope yeah, not to my knowledge, not yet.
Zinni's posed a question there, is if there is one lesson Malaysia can learn from Singapore, what would it be? Both Sumi and Chetna.
Go ahead, Sumi.
Think carefully, this is recorded.
The video recording will help you so much, though. We're going the way that everybody's going to wear those fancy glasses and everything's going to be recorded, right? I think oh God, I know there's one lesson.
You can give two lessons if you wish.
Okay, I think public engagement is very important. I think it should come at the start, right? It shouldn't be like halfway or whatever it is. I think if you're going to do it, do a good round of public engagement at the outset. And I think that public engagement has to, you have to prepare the ground properly, if you see what I mean. You have to till it, you have to water it, you have to fertilize it, right? You can't just kind of expect a fully grown tree to appear from the ground. So it's a process, right? Because people are not going to know about this. So it has to be titrated up in terms of how you engage with the public, and that would depend also to some extent on the cultural context. And maybe one more lesson, while the form is important, I think it's more important to have these bite-sized conversations that are recorded and that you build up a good relationship with your healthcare professional, so that when the time comes, there's probably going to be an agreement, even though it's not actually said, about what it is. There's a level of confidence amongst you about what you think you're going to do when the person loses capacity.
Chetna?
Yep, absolutely concur. I think in implementing the program in Malaysia, when we start implementing something as a national program, often we lose sight of why we were doing this and what it was all about, because we try to monitor things so closely. We want measurable indicators for everything. We want resources, we want funding. But I think, as Sumi said, it's important not to lose sight about why you were trying to put this in the first place. And the reason you were trying to put this in one place was because of that conversation that is so powerful, that is so important, that is patient. It is about patient-centered care. It is not about Goal Concordant Care. It is about patient-centered care. And if we keep that in mind, I think that would be wonderful.
Chetna, how important is to monitor and document the evidence for it?
Well, you're asking this to a researcher.
Absolutely.
I would say yes. You wouldn't know what's going on in the ground if we don't monitor, if we don't look closely. So, and this needs to be a continuous process. Don't wait 5 years to evaluate it. Keep monitoring what's going on simultaneously as you're implementing, so that, because it can be a loop, right? You find things are not going the right way, you can take corrective action to get things back on track. Or maybe things need to be done differently based on your experience. And I really look forward to hearing maybe once it gets rolling off the ground, or what your experience is. It may not be the same as Singapore experience.
It probably will not be the same as the Singapore experience.
So yeah, I mean, just sharing that experience and knowing what's it all about and how things are going. That's why we monitor and evaluate.
Dia has another question. Dia?
Thanks, Ednin. So, Chetna, you mentioned in your presentation about cultural barriers. Can you explore which elements of ACP do you mean? Is it the documentation part? Is it the future planning part? Is it a prognostic discussion part, or is it involving patient in a process of foreseeing their own future part? Really curious. And what does this mean to ACP in Singapore?
It means all of what you said, Dia. So what it means is that patients may not be prepared yet to have these conversations. They may not think it is important for them. They may want to relegate decision making for the caregivers. They don't want conversations that take out hope, because hope is really important for them. So we need to take all of these factors into account while having these conversations. In fact, we were just having this discussion. So our center recently adapted the serious illness conversation guide, which was came about from Ariadne Lab. So we adapted that to the Singapore context. And there was extensive adaptation that happened because patients just didn't want to hear about prognosis. Questions about trade-offs were very difficult for them to answer. They didn't want to think about it. They wanted conversation that gives them hope. Right? So we had to extensively adapt the questionnaire, the guide, to our context. And that's where the cultural part comes in. And I think that's very important to get it right. Because if patients get turned off when we ask these questions, they are not going to open up and they're not going to talk about what matters to them. So, yeah. Did I answer your question, Dia?
Yes, thank you so much, Chetna. And I hope you would want to share your. Is it already published, Chetna, the adaptation?
Oh, we just submitted it. So
Okay,
hopefully
yeah.
in a few months, fingers crossed.
Okay. Thank you.
Dia, I know that cultural issues are something that you're interested. Do you have an opinion on this?
No, Ednin, thank you.
Chicken. So Sylvia's raised a very interesting question. How do you evaluate a healthcare system's readiness practically and culturally to support ACP? Both Chetna and Sumi. I think this probably might be the last question.
So that's a tough one. There's no single measure, I would say, to see whether the healthcare system is ready. There's so many aspects to it. It's about public engagement. It is about developing a model of ACP that is culturally relevant for people, that people accept. It is about having that IT system in place. It is about training people. So ACP is a complex program. There's so many different parts to it. And we need to get all of these parts. So we need on the table, we need the clinicians, we need the ethicists, we need the lawyers, we need people from IT, we need patient reps, we need caregiver reps, we need researchers. So we need everybody on the table to get things going.
Yeah, I totally agree with that. I do think as well that you do need buy-in across. One of the big problems really, and maybe it's okay to start if you haven't got 100% buy-in, but I think you need to have significant buy-in from the key players, and certainly at the outset, then to bring the others on board. And and in a in a multi-ethnic and a multicultural and multi-religious society, I think there's got to be very good awareness and execution when we're having these conversations, that there's an awareness of that, because we really need to be respecting, the different beliefs and values to the extent that that's possible, that we can do that within our system and in relation to the care that we can deliver. Yes, government support certainly would be ideal.
Yeah, you need policymakers on the table as well. Absolutely.
Thank you, Sumi and Chetna. Sorry, Ednin's seems to be having trouble with his line, and he just asked me to take over. But I think I'm basically here to say thank you very much to everyone. It's been fascinating, and I could keep bombarding you with questions for a long, long time. It's raised many thoughts of, I think, one question that came to my mind was also, do we just throw ACP out and focus on communication skills training right back at the beginning? But I'll leave you with that. So I'd like to take the opportunity now to say thank you very, very much, both to Sumi and Chetna, for giving up their afternoon and sharing this. I think it's been very, very valuable for anyone who's thinking about going down the road of ACP. It's so useful to hear your experience, and above all, to see how carefully it's been evaluated. So thank you very, very, very much, and thank you to the audience for their questions. Thanks. Over to you, Kai. Have we got Ednin back here?
Yeah, I'm back. Got disconnected for briefly, but thanks very much, Chetna, Sumi, everyone else who's joined in. Hope it's been interesting and helpful for all of you in wherever you're practicing.